Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magana.
Welcome back to EM Pulse.
Sarah, it's starting to get hot outside in California again, and it reminded me it's getting hotter and hotter out there.
Yeah, I think about that when I'm driving into my shift and it's over 100 degrees out there, and I think about how very much energy I'm going to use on my shift that day.
I do too, and I know so much of it is very necessary and saves lives, all the waste that we have, the gloves, everything, but I wonder if we could reach that balance between waste and my environmental footprint and safety. Somewhere there's got to be a safe spot.
So to explore this, we brought back our colleague, Dr. David Barnes. He's a professor of emergency medicine at UC Davis and director of ED sustainability and a member of the UC Davis Health Sustainability Committee.
David, what does it actually mean to be the director of ED sustainability?
That means that I get to sit on committees and attend a lot of extra meetings. It really means that I am the point person when it comes to sustainability initiatives and efforts that affect clinical care in the emergency department. So it allows me to interface with our larger sustainability committee, our procurement team, and others who have a footprint in the space of healthcare sustainability.
So to be clear, UC Davis Health has its own sustainability committee, and then we have our own departmental one, and you're like our representative on that bigger committee and also looking at everything in our department from a sustainable lens. Is that a fair summary?
It's close. We have a UC Davis Health Sustainability Committee that's comprised of probably 50 to 75 individuals, from physicians to our sustainability officer to professor emeriti. We have nurses, we have students on the committee. There's some residents and fellows and staff across the organization. So it's really a diverse group. We don't have a formal ED sustainability committee, but we do have a number of individuals who have drive, interest, and passion in this space. And we work together on initiatives from time to time.
David, why did you decide to put your efforts into that vein of work?
Well, I think at my heart, I'm probably a tree hugger. And so I initially got into this work because I was concerned about the environmental impact that healthcare was having, whether it's plastic waste or the impact that anesthetic gases have on greenhouse gases. I felt like it was my duty to kind of do something about it. As my work in this space has evolved, I see really a broader impact that sustainability has, not just the environmental impact, but on waste reduction, on cost reduction, on organizational resiliency. And so I've actually become more fired up about this than I was in the past.
That's interesting. And I like looking at it from those other lenses. Probably makes it an easier sell for those that are non-tree huggers as well.
Oh, for sure. And there's a lot of controversy around climate change and things like that. I don't think it's controversial that healthcare is a wasteful industry. I think there's a lot of intrinsic good that comes from reducing waste, reducing cost. And you don't have to believe in climate change. By the way, it's real. But you don't have to be a tree hugger, I think, to care about the issue.
Let's look at it through the emergency department specifically. What does sustainability mean in the ED setting to you?
I think generally what sustainability means in healthcare is the delivery of efficient, affordable care that avoids waste, but is also clinically meaningful, clinically safe. You mentioned it in the introduction. We don't want to sacrifice patient safety for, saving a few pounds of plastic. There is a balance, and I think healthcare as it is delivered now is extremely wasteful. There's a lot of room in there that we have to claw back, where we can reduce our impact, we can reduce the supply waste, the inefficiencies associated with the delivery of safe and effective care.
Okay, so it's creating something that can last into the future that makes sense from a safety perspective, but also makes sense from a utilization of resources perspective.
Right. I think what you're getting at is resiliency.
Yes.
Right. Absolutely. A healthcare system that is inefficient is not resilient against things like supply chain disruption or energy grid disruption when there's a heat wave. When you have a organization that is focused on sustainable healthcare, that has renewable energy, it has its own microgrids, it has supply chain contracts in place that prioritize sustainability, that organization is resilient when disruptions come. Again, whether they're weather or climate related, or whether they are related to a conflict in the Middle East and the ability for supplies that are manufactured overseas to get to the United States. It's all interconnected.
So let's bring it back to the ED. What are some ways that we are wasteful and not sustainable?
I think two common things come to mind. Number one is we are very resource intensive with patient care. We have a lot of medical supplies that are used that are energy intensive to manufacture, but they're also packaged in ways that are not to use the term too much, but they're not sustainable, right? We're heavy on single-use plastics. We're heavy on supply kits that are largely unused. There have been some studies that have looked at things like central line kits, and something like 75 to 80% of the instruments and the materials inside those kits goes unused.
No.
Yes.
Yeah, I've seen people open up a separate kit just to get another wire.
That happens. Our workflow is dependent on things that are outside of our control. Take, for example, the way that individual saline syringes are packaged. The sterile stuff's on the inside, but they're wrapped in single-use wrappers that immediately go in the trash and really provide no additional safety benefit.
Yeah, that's a really good point. In the emergency department, we pride ourselves on always being prepared and ready for an eventuality. And, I think about all the times that I've opened up 3 ET tubes in anticipation of a child's size. And then they get here and they're like crying and, reaching for their mom on the gurney. And I'm like, well, that was 3 ET tubes that are down the drain. In my priding myself on being prepared, what did I gain there?
Preparation comes at a cost, right?
Yeah.
Think about the last trauma resuscitation that you attended, where you've got 12, 15 members of the trauma team who they're ready to go. They're gowned, they're gloved, and the patient shows up and it's a bump on the forehead. And now those 12, 15 gowns, the 30 plus gloves, the shoe covers, the head bonnets, those are all doffed and go in the trash and were never really necessary in the first place. So that preparation definitely comes at a cost.
Okay, single-use supplies is definitely an issue. What about farm waste? Is that a significant issue inside of the emergency department?
It's definitely an issue. Pharmaceutical waste contributes significantly to Scope 3 emissions. If you have questions about Scope 1, Scope 2, Scope 3, we can talk about that and unpackage that later. But pharmaceutical waste is a major contributor to Scope 3 emissions. And I see this in the ED. I also work in our burn unit doing sedation. And the drugs that we use are manufactured and packaged in aliquots, for lack of a better term, that are generally what you might need, right? But there are plenty of times where you need 1 cc out of a 10 cc syringe, or we hang a bottle of propofol that's 100 mils and you use 5 mLs and the other 95 go to waste. And because of the regulatory environment that we're in and a necessary focus on patient safety, we don't reuse those or reclaim those, and they're discarded. And by the way, it's regulated medical waste, which is a lot more expensive and energy intensive to dispose of.
Yeah, how many times have you just pulled up like 2 mLs of lidocaine from that large bottle?
All the time.
Right?
Yeah, okay, David, take me back to those scopes. What are these different scopes, 1, 2, 3?
Yeah, so the scope of emissions, I think, is a useful framework to think about the direct and indirect emissions that are produced by an organization. So Scope 1 emissions are those emissions that are directly produced by the work that's being done by the healthcare system. So we have the burning of fossil fuels, gasoline, for the thousands of fleet vehicles that drive around UC Davis to, drive PO&M around or to deliver supplies from the main hospital over to the ACC. Even the police vehicles that are sitting idling, those are Scope 1 emissions. Anesthetic gases that are leaking into the environment, refrigerants that are used to heat and cool our buildings, those are Scope 1 emissions. Scope 2 emissions are those emissions that are related to the energy and the fuels that we purchase to run this place. So this is the energy that we get from SMUD. It's the steam that we use from, whatever supply lines that go into turning the turbines over at the FSSB. Scope 3 emissions, which makes up the largest proportion, actually, of emissions. The first two, 10 to 20% each. Between 60 and 80% are Scope 3 emissions from an organization like UC Davis Health. And those are things like employee commuting, the waste disposal that goes into burning regulated medical waste, devices and equipment that are thrown away, travel to business conferences, even meat production. This won't be popular, but meat production that we serve, right? There are significant emissions related to the production and processing of meat for our consumption. Those things are much more under our control than the first two.
But I do see, the emissions that you're talking about, nitrous and some of the other things that we use in the emergency department can leak out. And then just by being prepared means that we're open 24/7, all of our rooms, all of our lights on. We're ready for anything, anytime.
We're constantly cooling or constantly heating our buildings.
Yeah.
We have lights on all the time. We have employees coming and going, traveling to and from all the time. Right. It is a continuous process of preparation, and that comes at an energy cost.
Yeah. And so, many people say that impactful change or truly impactful change must be done on a systems level. And we will get there. But let's start with the individual level, since this podcast is geared toward the individual. What are 2 things that a single clinician can do on their next shift to make their own practice more sustainable?
I think the most important thing that the individual can do is to take what you need and leave what you don't. I have so many examples of asking someone for a particular medical product, again, whether it's a pair of gloves or a syringe, the pre-filled saline syringes comes to mind, and someone comes up and hands me 50. And I know I'm just going to need one, right? But now we've created this unfortunate circumstance where now our infection prevention priorities start to creep in, and those extra syringes or extra gauze or whatever the supply happens to be ends up in a room, and let's say it's a VRE room. Those extra supplies that aren't used aren't coming out of there. They're going in the trash. And so being mindful and being very deliberate about what we need, what we take, and what we use for a particular patient, I think is probably the most meaningful and impactful practice change that we can have. Another thing that we can do is be mindful of waste segregation. I think every ED has distinct waste collection bins. There are standard waste bins and red regulated medical waste bins. And I can't tell you how often I happen across a red waste bin and I see coffee cups or PHI or something that's in there that shouldn't be. Well, guess what? Nobody's going to thumb through that and pick out the non-medical waste before it's discarded or before it needs to get incinerated. And that red waste is actually about 6 times more expensive to destroy than standard waste. And that, because it's incinerated rather than going to a landfill, it creates significantly more greenhouse gases than just disposing of that coffee mug into a landfill.
Those are really practical things. I like that. One of the other things that I think about is using reusables when my workflow allows for that instead of those single-use things. And, kind of like what you're saying, use only what you need is also ordering thoughtfully, like not ordering tests that I don't want sometimes.
No, I think that's great, and it definitely gets into the choosing wisely philosophy of ordering tests or studies or supplies or procedures or whatever the intervention is very deliberately with the idea that it should be medically necessary. It shouldn't be a fishing expedition. It shouldn't be just in case. And I think that it definitely fits within the overall sustainability mindset.
Okay, let's look at a department level. What are a few things that we can advocate for within our own departments?
The first would be having either a local sustainability committee or a larger organizational committee. Because the ED is such a resource-intensive environment, I think we're probably some of the best folks in healthcare to drive initiatives like that. And so coming from the department to hospital leadership and saying, hey, we don't have this, we really need it, I'm willing to lead it, I think that would go a long way of changing organizational culture and getting others on board, especially leaders like CEOs, CMOs, chief operating officers, people who are in a position to make decisions about contracts and purchasing, and that can really drive organizational change. But it really has to be grassroots, I think, from the clinicians that are on the front lines and seeing firsthand how wasteful healthcare delivery can be.
Yeah, speak up about bad system design makes a lot of sense. And it is more powerful when we come at it together instead of just one lone voice representing a group of people. Makes a much more powerful shout.
Absolutely.
I know with COVID, we all had to rethink how we were going to get here. And we saw a significant decrease in emissions during that brief shutdown period. Are there any principles that departments can employ to help reduce how we're commuting and emissions and how our own individuals work?
I think offering telecommuting or online meetings, especially when those meetings are kind of solitary throughout the day, it always bothered me when I had to drive in from home, across town through traffic for a 1-hour meeting. And is there the personal connection that's sacrificed by doing that? Sure. I'm not doing that every time. If I happen to be on campus, well, then I'm just going to go to the in-person meeting. But having that as a viable alternative to multiple people coming in for a 1-hour meeting that can just as easily and effectively be done over Zoom or over Teams or whatever, I think that's a workable solution, and it makes a meaningful impact. First of all, on people's well-being, right? You're not spending an hour driving in for an hour meeting, right? But it also has an impact on Scope 3 emissions, reducing your carbon footprint. You scale that to the size of an organization like UC Davis, where we have something like 15,000 employees, you start to make a meaningful impact.
Yeah, so let's bring it back to that system level. So we talked about using our voices to advocate. What is one thing that we can ask our systems to do better?
Just one?
Oh, give me more.
I'm probably biased in my response, but I've seen significant progress in our organizational prioritization of supply reprocessing. Something that I've always sort of cringed at when I see it is something like a waffle mattress or some other device that was originally designed to be single use, to be used one time. And it could be for something as short like transferring a patient from an ambulance gurney over to a hospital gurney, and then it gets thrown in the trash. So we have a partnership with Medline, which is a medical company that reprocesses a number of our previously single-use devices like laryngoscope blades, EKG leads, waffle mattresses. There's a few others that I'm probably missing. We have partnerships with companies like Stryker to take ligatures, which are surgical instruments for tying off veins and arteries and things like that. Those instruments are collected in specific ways. They're taken back to the company, they're reprocessed, and they're reused. And that reduces significantly the amount of energy and materials, raw materials, that go into otherwise creating a brand new piece of equipment. And so again, you scale that over an organization our size. I don't know how many surgeries we do per year, but it's tens of thousands of surgeries per year, right? And that's just the impact it has on the OR. Think about the number of patients just in the ED who are on waffle mattresses. And those were single use, immediately went into the trash, which go to a landfill. And so by taking those, reprocessing them, and reusing them in an acceptable, regulated, IP-approved, infection prevention-approved manner, it just makes sense. It makes fiscal sense. It makes environmental sense. And from a sustainability lens, I think it's hard to argue with.
How have you found this to be received within inside of our system? And what are some of the ways that you have overcome any barriers?
I certainly concede that there's a difference across different generations. For physicians and nurses and other healthcare professionals who are brand new to the profession, they are hungry for this. It's just sort of what they've grown up with. It's what they learned in high school and college, and it's just part of the culture. For older physicians, older nurses, older pharmacists, the passion, the drive, the fire isn't as hot, but there are plenty of individuals, some my generation, some who are older than I am, who are really fired up about this. And they, I think, have had the luxury, if you can call it that, of looking historically at how maybe things used to be. There's a surgeon I work with on the sustainability committee who remembers the good old days in the ORs where they used cloth gowns. It wasn't the disposable paper or plastic stuff that they're using now. And so we sort of come full circle. You know that we're starting to use reusable gowns in our department. They're less expensive. They have a much lower carbon footprint. They have a much lower life cycle impact because they use less water to manufacture and even less water over the life cycle of cleaning them. So we sort of come full circle to bringing it back to something sustainable like that. So it runs the gamut in terms of support, but there's definitely a generational difference, if you will.
What tools have you used to engage those that are the naysayers or those that are a little bit more hesitant?
Some of it is easy, Julia. The government says you have to do it. For example, with our paper reduction project that we started about 3 years ago, we changed to double-sided printing for all of our clinical printers. So anytime a patient was discharged from the emergency department, rather than getting 10 pages of an after-visit summary, they got 5. Right off the bat, we cut paper usage by 50%. It was relatively easy. Part of that same paper reduction initiative was the e-prescribing. Well, the e-prescribing was something that we had thought about and we were doing, but there was no statutory or regulatory requirement for it until the state of California said we had to do it. And then it was easy. You just have to do it, right? And then nobody pushes back because it's a regulatory thing. It's a law that you have to follow. For things that are voluntary, that's when education, awareness, signage, modeling the behavior, and actually calling things out to those around you. For example, the yellow gowns in the trauma bay. When we first launched that program, the yellow gowns, by the way, are reusable, washable. They have a life cycle of about 90 washes rather than those single-use plastic gowns that we used so much of during COVID. But when we first launched that project, there were plenty of people who didn't want to wear them. So what I would do and other advocates would do is we'd put the gown on, we would walk into the trauma room, and we would talk about the gown that we were wearing. We would actually use it as an opportunity to teach people about the difference in life cycle and energy consumption for manufacturing of plastic single-use gowns versus what we were hoping people would buy into. Now, the tables have turned. You walk into the trauma bay and almost everybody has a yellow reusable gown on now. Very few people have the plastic gowns. So initially I was really frustrated. I wanted to lecture people and wag my finger at them. And over time, I just saw it as an opportunity to drive behavior by modeling the behaviors that I wanted to see.
Okay, David, something that you and I have spoken about before, and I really don't have a great comprehension of where this came from, is the use of gloves. When I first started medicine, we used gloves if you were going to get wet, was essentially the principle. Like if you're going to touch something that's moist or wet, use gloves. If not, you don't have to use gloves. And I feel like now I'm seeing trainees coming in and they're putting gloves on and they're not even touching the patient. I'm like, what's going on here? How much has our glove use changed? And how is this the right thing? Am I behind the times? Walk us through proper glove use here.
I think that's such a great observation, Julia. The amount of gloves that are used at UC Davis has actually recently been quantified. There's a big focus on it. What our glove utilization is, both proper and improper. I don't know if there's a right answer to the question of why this is happening. My own observations are really twofold. Number one is much of our practice has been driven by infection prevention and just sort of the secular culture that has evolved over time of nosocomial infection awareness and reduction, and the acceptable practice of donning gloves regardless of what is in the room, right? It's habit, essentially. I definitely saw an uptick in glove utilization during COVID. Everything about our fear of contamination, our fear of infection really just grew exponentially during that pandemic. And we're not so bullish on gowns anymore like we were back then, but the glove issue seems to have persisted. And as an organization, we're actually prioritizing that. So our chief quality officer and our sustainability director they've quantified the issue. And there's actually an educational initiative that has gone out, as you all know, because I shared it with you, that has provided some guidance to clinicians who are taking care of patients, as well as ancillary staff like food and nutrition workers who deliver food to the bedside. We were seeing those people wear gloves as well. So most of it is driven towards, protecting the staff that's going to the patient. But in some cases, it's actually protecting the patient from the staff, whether it's a nosocomial infection or maybe a wound on the hand. But the vast majority of encounters that we see probably don't need the clinician, the examiner, whoever, to be donning gloves, because it's not an encounter that risks any contamination or infection either way. So I think having an awareness of it, knowing when you need gloves, and more importantly, when it's okay that you don't don the gloves, I think is the first step. And they'll be starting some audits, and we have a couple of initiatives to reduce glove waste that are kind of in their infancy. So,
yeah, and this comes back to your idea of modeling as well, and just kind of sharing that information. And culture change takes time. So, hopefully over the years, we will see an improvement.
Patience and persistence are the two lessons that I have learned over this journey. Definitely not ramrodding this stuff down people, not shaming them, but educating, drawing awareness, and just being persistent about it. We've had our yellow gowns in our trauma bays for years now. I think it's going on 3 years. I still walk in to the trauma bay with my yellow gown and I still call it out. So it's just part of my practice. And here we are 3 years later, and now it is the dominant practice. So if we could do that with other things like gloves or single-use plastic devices or instruments or supplies that are brought to the bedside, I think we'll start to see a culture change over the next few years.
David, do you have any favorite resources that people can turn to learn more?
There are a number of organizations. They all have websites. I think they all have Instagram pages as well that are focused on healthcare sustainability. Practice Green Health is probably the one that is most well known. UC Davis is a member of Practice Green Health. In fact, we've won a number of recognition awards over the last few years, both in our delivery of healthcare, our waste reduction, our supply chain sustainability initiatives, even our cafeteria food and nutrition services and the way that we dispose of food waste. And our composting programs have won awards through Practice Green Health. So it's nice to be recognized for the things that you've done. But I find that they're really a great resource for best practices. And a lot of outstanding healthcare organizations around the country really around the world that are doing other things that we may not have thought of. And so having it as a resource, they have an annual conference that I've attended where you can learn from others in this space and then bring those practices back to your own organization. So that's probably my favorite resource. There's also Green ED, which is run by the Royal College of Emergency Medicine out of the United Kingdom. That is a grassroots sustainability organization specifically focused on, they call it A&E across the pond, but specifically on emergency medicine, emergency department sustainability. It's all comprised of emergency physicians and nurses and other clinicians that work in the emergency department. And it's geared towards changing practice and partnering and working with organizational leadership to drive sustainability changes throughout the rest of the organization. The last resource that I would recommend is Healthcare Without Harm. Very similar to Practice Green Health. It is clinician-focused. Practice Green Health is more organizational-focused. Healthcare Without Harm is more practitioner-focused in terms of providing education, resources, best practices, and even a literature base to clinicians to drive their sustainability initiatives to reduce waste, to practice clinical medicine efficiently, and to reduce eventually their carbon footprint with how healthcare is delivered.
Well, those are really practical. Thank you, David. I appreciate your time, your expertise, and what you're doing for our department and for sharing it with our listeners. So thanks.
Thanks so much for having me.
And thank you to our department for investing in ways to be more sustainable.
And thank you to OM Productions for creating sustainable podcasts.
So until next time, stay curious, stay inspired, and stay tuned.
The opinions expressed on this podcast are those of the hosts or guests and do not necessarily reflect the views of UC Davis Department of Emergency Medicine, UC Davis Health, or their parent organizations.